Namaste, Ram Ram, Kali Vanakum, Soprapat, Kaskai Mumbai. Thank you all my friends for joining. Sorry about some of the technical issues. I'm new learning to this Zoom. I'll ask the panelists if something isn't right in the video to let me know, or if the participants, people who are watching, if something doesn't look right, let me know, or let one of the panelists know. And then I'll get it straightened out. And there will be a Q&A after the presentation. This presentation is going to be, for some of you, new, and for some of you, it'll be a review of what Dr. Jones called counterstrain technique. My own personal history, this I learned in my sophomore year of osteopathic medical school, which is kind of funny because this is a really easy technique to apply. We actually started school with some very difficult things, and then they taught us this later. I think they should have taught us this first. If the first rule of medicine is do no harm, this is something that can be done very easily. Either you have a nice result or you have nothing of a result, but you don't hurt anybody with it. This technique was developed by Dr. Jones, Lawrence Jones, and he actually discovered it accidentally. What he discovered was that by taking maximum tension off of a muscle or a ligament, he was able to relieve and get some long-lasting change in an area that was painful. And the story that he told in our school was that he actually had a patient with an acute psoas spasm. He couldn't get the guy comfortable. It was coming up to lunchtime. So he put the guy on the table, put a stool under his knees to lift his legs, put some pillows under his head to try and get the guy comfortable, and then went to go eat some lunch. When he came back, the guy had no pain. Then he went to try and figure out what had happened. That's usually how science works. We observe some phenomena, and then we go back in time and try and explain how did that happen. So our principles and our theory in counterstrain is actually quite simple. And I'm going to give you the simple part first, and then I'll get a little bit more complicated. The simple part is we palpate something that we call a tender point or a Jones point. Later on in another lecture, we can argue about other types of points, trigger points, Chapman's reflexes, and so on, and talk about whether or not it is applicable for counterstrain. But in the simplest view, anything that you would like to either reduce the tension or reduce the pain, it's worth a try. Again, if the first rule of medicine is do no harm, this is a very easy thing to apply to see if it works or it doesn't. So you position the patient with the idea of maximum decreased tension regarding whatever it is you hope you're treating, the ligament, muscle, tendon, fascia. Dr. Jones theorized that this would interfere with the gamma gain that he believed was responsible, that there was a dysfunctional gamma gain. Ideally, for this to work, you want 2/3 of their pain or their tension to be gone. Now, these are rules that got built by Dr. Jones when it became something to now teach as a course, okay? So when we say ideally, you would like to achieve 2/3 reduction of discomfort, no, ideally, you would like it all to go away. But the idea of 2/3 is that if you don't get most of this to change, you may not have a long-lasting change. So we're going from an experience that Dr. Jones had to now creating rules for something that can be taught and replicated in osteopathic medical schools. Gamma gain, this involves the gamma motor neurons. This is now theory. After Dr. Jones saw what happened and he tried to say, why did that happen? He theorized that the gamma gain was what was being changed and that this would affect the muscle spindles. Gamma gain is like your volume control on a speaker that modulates the sensitivity. So his theory was that that there was an altered gamma gain, too high or too low, that was responsible for whatever tender point he was palpating, and that's what was being changed. But to be clear about theory, if the theory turns out to be wrong and the clinical experience turns out to be right, then I don't worry too much about the theory. The theory is an explanation after the fact. Principles continued. The idea is to fold the body around that tender point until you get, hopefully, a 100% reduction of discomfort, but at least 2/3 reduction of discomfort, and then hold it for 90 seconds. Another nice thing about Counterstrain is that this is all patient passive. For patients that can't follow your directions, patients that won't follow your directions, patients that are deconditioned, severely debilitated. So this is completely patient passive. You put them in a position, hold it for 90 seconds. The theory is that 90 seconds was a passage of time that would allow a new set point to be achieved through the gamma gain. Then return them to their original positions, recheck your findings. So, and it's quite important that when you return them to their original positions, you do this passively. You don't want the person to activate the muscle and then to re-engage the pain or re-engage the tension. The idea of rechecking your findings is to see whether or not the technique worked. It either worked or it didn't. So if the technique was successful, great. If the technique didn't work, I'm not going back to do Counterstrain again. I'll go on to some other modality. Practically, what's the practical implementation? There's nothing that I have invented in osteopathy. I have my own viewpoint on things, and this is my viewpoint. When we were in school and we were given these rules, 90 seconds, 2/3 reduction of pain, you should have seen us in class. It was actually quite funny. We're first of all young people working on other young people that don't really have a complaint. And we're trying to see if we got some tender point to at least 2/3 reduction of pain. And so we're asking them, how do you feel? And you should see all the craziness that comes out. My contribution to Counterstrain is language. It's really simple. I move you in a direction I simply need to know. Is it better, worse, or the same? That's all I need to know to tell me whether or not I'm going in the right direction or I'm following the right path. So initially engage one plane of motion, move them to where you think it works, and then do small motions. Is it better, worse, the same, better, worse, the same? At some point, you will max out in that one direction, and then you add another direction cumulatively. So I made this chart to kind of give you an example. If I have this continuum here between extension and flexion, let's say in the cervical spine, at some point, it doesn't have to be the point between flexion and extension as I have drawn it. This is just an example. Let's say this is the perfect point where there's no discomfort or the least discomfort. So as I'm moving, it's better, better, worse. That's how this is useful as an idea. Sometimes if you move them too much too fast, you may miss this type of spot by going, it's better, it's the same. And you've missed this because you're moving too much. Better, it's the same. When in fact, there was a better spot here. That's what's meant by this diagram. The other difficulty that I find is not in the technique, it's in communicating with patients. And later in this lecture, we will remove the communication. That's the easiest way to do this. But the way that Counterstrain is taught around the world is by verbalizing their pain. So if I'm constantly in a quest to see this pain go to 0 or go to at least 2/3 reduction of pain, I found that people cannot give you calculations. Smart people become stupid when you talk to them and say, how much pain do you have left? No one can seem to understand it, but everyone understands money. That's the simplest way. Do you feel 66 at 0.7% better? No one can do a calculation like that. But since we're in India today, if you started with 100 rupees worth of pain, how many rupees are left? That kind of math everyone can do. And it can tell you if you're getting into the, I have 30 rupees left, I have 20 rupees left. You're in the therapeutic zone there. So 90 seconds is what Dr. Jones theorized. This is after he has done the clinical work in the clinical world and found his technique was working. Now he has to create rules to teach this to other people who maybe aren't clinical, or maybe they're learning clinical, or they don't have the clinical experience to feel that. So he said 90 seconds is required to achieve that new set point. And I see I'm learning this as we're going as well. I see that there's a hand raised, so I will answer all the questions during the Q&A. So feel free to type in your questions and they will all get answered during the Q&A. After the 90 seconds, whatever success you've had, you slowly return them to their original position. And you want to do this passively. You don't want the patient activating any muscles. And then you recheck your findings. How is it better, worse, the same? If they say the pain came completely back, there is no point in doing a counterstrain technique again to that spot. Perhaps it's the position that's causing it. Perhaps it's a nerve impingement. There may be many other reasons why they have come back and still have that pain. But if you have applied the counterstrain correctly, there's not a reason to do it again. What I've done here is I have retaken photos from the original counterstrain book, which was actually very not too user-friendly. And I've just created my own pictures with what Dr. Jones originally had for common counterstrain points. Dr. Jones, once you take a clinical experience and then you want to now turn it into something that's going to be taught in medical schools, you have to start making other correlations. It can't just be that this makes people feel good. So he started correlating these tender points to bony landmarks. And he said this tender point is on the spinous process of C4, 5, et cetera, articular pillar tender points over here. And he created rules. And the rules were, we memorized them. They were like E straw, F straw, E, S, T, R, A, W, extend the neck, side bend towards, rotate away. They were exact motions that you're supposed to do and hold for 90 seconds given on tender points on these areas, okay? Why did he create those rules? He found that they worked reasonably well, and he was teaching these to medical students. Osteopathy in the United States is medicine, same as the MD. Most of the people I went to school with are never going to do any manipulation or palpation. So you need to give them a formula. Maybe they don't feel the release. So you have to give them a formula. Turn it this way. Following it the way that I am instructing you, it's going to be by your feeling or by the patient's improved feeling. So you don't need to memorize any positions. And the memorized positions don't always work. So you need to be able to do this by palpation. But I want to give you the original diagram, which is he tried to turn this into a bony model. So what kinds of things did Dr. Jones say that he was counterstraining? Well, spinous process, interspinous ligaments, articular pillars, muscular structures in the neck, rectus capitis, splenius surfaces, and so forth. That's what he listed might be responsible for these tender points. These are some common positions and some easy ways to do counterstrain to the neck. What I want you to see from this picture is you need to have control. You need to hold the head nicely so that you have a nice control of the head. If you're not holding them and controlling them, then they will start to support their weight. And this is a patient passive technique. Okay, so you need to have comfortable control here. And from here, I can go through all the planes. I can lift my fingers and cause some extension. I can do some rotation, lateral flexion. I can do everything I need to do quite simply. The anterior neck, this is much less frequently applied. Again, I have reproduced the old black and white photos that Dr. Jones did with my own photos with the exact same tender points and the exact same instruction to show you how it originally came from Dr. Jones. Again, he related these to vertebral processes that would be in dysfunction, or in case of AC8 would be a nerve root 8 on the brachial plexus. and this would be nerve roots C1. So again, you're taking an experiential model and turning it into a bony model. The reason why I say this is an application I would use much, much less is all of these points are corresponding, except for C7 and C8. All of these points here are corresponding to what bony structure underneath? Well, it's the transverse process. And this is the lateral mass of C1. Pushing on any of these spots is going to be painful in a normal person. So I don't know that I'm going to make that pain go away. But if I have pain that is nearby, this is where I can apply this technique with the same idea of reducing tension or reducing pain. So what kind of things did Dr. Jones say we were doing anteriorly? Lateral mass of C1, transverse processes, sternocleidomastoids, scalenes, even to some lesser degree, possibly the edge of levator scapula. So here's some types of hand positions. Again, you can't see my other hand underneath controlling the head, but you palpate a spot, you palpate whatever it is you want to palpate, and then you take them through motions one at a time. So you take them through a motion where you think it will work. If you're on the left side of the neck, you can do a little bit of flexion, a little bit of left lateral flexion, and say, how are you? Better, worse, or the same? They say they're worse, then you change one direction. The moment where they say they're better, you go along that single plane until you maximize it, and then stack the other planes. We learned that sometimes as I said, we had to memorize points, and each point had a particular way we were told to move it. And they worked a lot of the time. Sometimes they didn't. When they didn't, we were told that they didn't because they were maverick points. A maverick in English is a reference to a horse that is a wild horse, something that doesn't obey the rules. So we were told, well, these points are just maverick points. And that's the only explanation that I got. But I have an explanation for you. Steve Sanet explanation number 437. I think maverick points, when you're able to make something go away that doesn't follow the rules of what you think it is. In other words, let's say you're in the posterior neck. Let me back up for a moment. Let's say we're in the back of the neck. What do I think I should do? I think I should bring their head into extension. But let's say I go into extension and I'm here and they say, oh, it's much worse. And I put them into flexion and they say it's much better. That's the idea of a maverick point. Well, my idea for a maverick point is maybe you're not counterstraining the thing that is under your finger directly. Maybe the reason why they feel better when you flex their head and you're on the posterior aspect is because it's the anterior longitudinal ligament. Now you're still bringing origin to insertion. You're still following the rules. It's just you're not palpating what you think you're palpating. So when we consider, this is just a short list of other possible things that might be involved. Posterior anterior longitudinal ligaments, ligamentum flavum, deep and anterior and posterior cervical musculature. And if we consider adhesions, which Dr. Jones did not, if we say that in fact you might be able to counterstrain fascia, then anything is possible. Anything is possible. There's scars that we don't see. They're not visible to us. So in fact, we can say maverick points may be obeying the rules. They do obey if we consider that we are in a different perspective. And my best way to describe it is like this. Just saying, I think I'm counterstraining something here, and I look to the Jones diagram and I say, well, that point corresponds to this structure. I don't know, am I doing one of the scalenes? Is it the platysma? Is it the ligament? I don't know what it is. But if the patient says they are feeling better and the pain is reducing, the technique can work, even if the science does not make complete sense. Another important point, you need to be comfortable. You need to be able to do this easily. In the neck, this is the easiest place to apply it. But in other parts of the body where we have to control them, you have to make every effort for you to be comfortable as an operator. If you're not comfortable as an operator, it's going to be very difficult to try and reduce their discomfort. I found this is a great technique. It does not have a world view. It does not have a key lesion view of problem, but it's a great technique to fix some simple things. There's an expansion on this idea, which we call facilitated positional release. This is Eileen DiGiovanna and Stanley Shiowitz. I learned from this guy right here, Stanley Shiowitz, and he was quite a character, actually. You have to understand that a lot of these doctors who came up with these techniques, they were country doctors. And what I mean by country doctors is they were not working in a laboratory, a scientific laboratory, coming up with ideas to help people. They were treating people with general medicine, which means back pain, neck pain, diabetes, blood pressure, weight problems, smoking problems, every kind of problem. But the number one problem that people also have when they come to the doctor is musculoskeletal complaints. So they had to find things that worked. Well, Stanley, he did a little add-on to Counterstrain, and it has this big long name, Facilitated Positional Release. And I will tell you the funny story that he told me directly. He said when he came up with this, it makes Counterstrain work very fast, not 90 seconds, just a few seconds. And then he went back to, at the time he was at New York University. And he said, we have to have a name now for a new technique. What should we call it? He asked the other people in the department, and they said, I.O., instant osteopathy. Well, of course, you can't have a name like that. Too much ego in that. So they came up with a long, complicated name for something really, really easy, facilitated positional release. It is essentially an addition to Counterstrain after you have done all the Counterstrain technique. So the principles are simple. Follow your Counterstrain principles, fold everything around each axis, get your maximum pain reduction. For this to work, you really need to get them close. You really want to get them to 70%, 80% pain reduction before you try and close the gap with FPR. And then the FPR idea is simply to distract or compress along each axis. Really, one axis should be sufficient. So for maximum effectiveness, you're not doing anything any different than you did in Counterstrain. Do everything you need to do, and then find a way to compress them. I will just go back to this simple example of the cervical spine. This is how we are moving in three directions. This is what Counterstrain is. I am bending my head forward and backward. That is flexion extension about a transverse axis. I am rotating my head. Rotation is about a longitudinal axis. It's the same kind of motion going around. Lateral flexion, it's motion around a AP axis. FPR is translation along an axis, compression or distraction. So if we can add this, do I still have to wait 90 seconds? No. If you're waiting for their pain, you can ask them, how are you? They will always tell you something. So when I feel that pressure go away, I just say to them, pain or pressure, because they want to tell you something. And they'll say, I feel pressure. Then I'm done. You can immediately begin to bring them back. Why was it 90 seconds? It's 90 seconds because Dr. Jones was teaching medical students who were not able to palpate or release, many of them. So he felt after 90 seconds, something should have happened. Again, going from a clinical experience to now something that you're going to educate to medical students. Okay, so you can do this to treat reduction of tissue tension. You don't even have to have the communication with them, which is how I'm applying it. The only time I'm applying it is a little bit for psychological reasons. In the beginning, asking them, how does this feel? They go, yeah, that hurts. I go through the whole technique. You have any pain there? No, I don't. That's the only communication I'm having. That adds a little bit of psychology onto it for them to believe that Dr. Sanet knows what he's doing. I get the benefit of the physical reduction of pain, and I get the added benefit of the psychological faith in Dr. Sanet knowing what he's doing. So here's some ways in which, some simple ways in which you might add this. Compression. This is not like a Sperling's test that you're gonna make their arms go numb. It's just the barest weight add onto the head after I've done everything else. Or I don't even require two hands. I can really just retract this bottom hand. That's enough to create that traction. But you want them in that 70 to 80% range for this to work. Okay. It's just a very finely nuanced, nuanced addition at the very end. Dr. Still, it was, you know, I'm third generation. I learned from people, actually, no, I'm second generation removed from Dr. Still. And there are people that learned from him that said he did not allow pen and paper in class. He didn't want people to memorize techniques. He wanted them to understand the anatomy and physiology so they could create what they needed to create. When we do the Counterstrain module, we do 3 days of practicing individual nuances for different body areas and different difficulties, and we have a lot more time. But this is the essential theory right here. Knowing the theory and working with it, it is possible to create what you need for any given situation. I'm not guaranteeing you that Counterstrain works for everything. I don't know anything like that. What I'm saying is I can apply it to any situation. You can apply it to the most painful patient. You can apply it to the demented patient who can't follow your directions. You can apply it to the most debilitated patient. In just a few minutes, I will take questions. A tender point, a Chapman's reflex, trigger point. What is important to remember about these types of things is they're a very discrete area. So the goal is really to change some pattern and have not just a local effect, but a regional effect. So in order for this to happen, you need to have control of the patient so that you can achieve the maximum relaxation. If they're attempting to maintain their balance or they think they need to help you with the technique, this becomes much, much more difficult. So the science of Counterstrain is quite easy. And a lot of people like to compare, you know, science and art, and they have a difficulty with the blending of these two. Osteopathy is grounded in science, but the application absolutely is artistic. And the more artistic you can be with your touch, the more therapeutic you're going to be with your touch. I thank you all for attending.